Manju, please wait. She will give you a countdown. Apra you should start. Chitra, please give the countdown.
3, 2,
Sakiti.
1, go.
Good evening. I welcome you all for this August webinar of our AART. Today's talk is about cost minimization in IVF in the era of the new ART bill. Can I have the CV of Professor Jayam Kannan, Madam, please? Madam was Vice President Foxy 2018, Foxy Adolescent Health Committee Chair 2013 to 15, Managing Trustee Vice President Foxy 2018, and she was a Free Legal and Center for Women Trichy since 1992, the President, and member of PMNCH WHO since 2008, Post Director Certificate Course in Reproductive Medicine Foxy since 2012. Her major achievements are President of India Medal for Outstanding Performance in MBBS. She was a winner of 13 medals and prizes in MBBS, State First in MBBS, University First in MD, Best Paper Award 4 times. She has Best Book in Medicine Award 2 times from the Government of Tamil Nadu. She won the Durusha S.N. Pandit Award, Foxy Community Work, and the Best Committee Chairperson. Her Lifetime Achievement Awards from IMA, Tamil Nadu MGR Medical University, Trichy Women Association, Academy of Clinical Embryologists, Best Society President Award 2013, and her favorite award is the Tirumular Society of Siddhars. She has many publications in books in medicine in regional languages, 5 publications, and in English 1. She has won the Distinguished RCOG Service Medal Award in the year 2018. She is the first Indian to receive such an honorable award. We are very happy, and it's my great pleasure to welcome you here, Madam. Over to you, Madam. Thank you.
Okay. Thank you very much, my dear Manju. This society of this triple T goes with my family, which has originated from the Tiruvarur. Nearer to that, between Kordacheri and Tiruvarur, there's a village called Arpavur, from where my father and my mother also hails from that Nahapatnam area. And I was born in Tanjavur at Ellaiamman Koil Theru. I was educated in Tanjavur, and my life is going up in Tiruchirappalli. So I think I am one of the apt persons to be representing these 3 T's which have been taken up by Charmila. Charmila also almost has got same thing from Pattukottai, Tanjavur. Of course, she has an edge at Coimbatore a little, but I don't have an edge anywhere else. I have the edge only in these 3 places. So I hope I am a person representing all the 3 T's of this Academy of Assisted Reproduction. In this era of ART Bill 2021, in which Drishti IAS has brought out 2-page excellent details on this from the Ministry of Health and Family Welfare, are we able to do a cost cutting in ART is today's topic. The infertility, we all know well, is now a disease. It is no more a social problem. And the disease doesn't have any health issues, but it is a disease to failure to achieve a clinical pregnancy with unprotected sex, which is accepted by WHO. 2017 it started, and 2023 also it maintains the same words. The prevalence rising is amazing with 17.5 world over. What is the treatment for this disease? Biomedical intervention. It is not the clinician who is giving some tablets, injections, and comforting the patient or doing a surgery alone, but it is a biomedical intervention which has been aptly brought out. So with this biomedical intervention, it becomes inaccessible to poor sittings. And in Indian scenario, the out-of-pocket expense whoop makes the patient whoop. And if she is unable to exteriorize the gamete, which is the definition of ART, assisted reproductive technology is exteriorizing the gamete, which she is not able to do. Can we make her do is this talk. Cost cutting. At the cost of what? Disrespect to the patient, drain her time on pregnancy, take a delayed live birth, drain all her packets, emotionally get trained. No. ART bill has come out with very clear indications that we have to keep it up with all the resources available in the high developed countries, using highly complex IVF laboratories, but using it for Indian scenario. So what is the laboratories which are available in the last 2 decades in outside the country, which has not been seen by us, is the topic of today. Kindly note, this is the childlessness, that is permanent childlessness in India. You see, the Indian average is 6.3. See the Tamil Nadu average, it is about 10. That is why there are mushrooming of IVF centers in Tamil Nadu. People are going on saying, every alternate street has got an IVF center. Yes, because we have got double, we are almost coming to double the level of the where they're saying childlessness, that is permanent childlessness, compared to what is there in Maharashtra. And that being the case, should we not have more IVF centers? If anybody hereafter comes and says every street has got an IVF center, you tell them every street has got 2 childless couple who are permanent. Now, this is a data of 2001. 2021, the data could not be brought by the childlessness, mainly because of the COVID. Now you see the pink and blue, love me true, are the colors which extend the higher incidence of childlessness. Actually, the rural India has got more compared to what was there in 81, 2001. If you mark it now, it will be fully purple color in the present scenario. Urban India, again, the pink and purple, you see, more of purple color in 2001, but now if we take, it will be more of the red will be replaced by purple only. And there is a paper which has been brought from Mumbai, which has also confirmed that the Tamil Nadu has got the highest rate of these infertility problems by this year 2001. Do we mean to say the childlessness has increased in India? Please note, we were 7% in 2015 and 16, and we were 12% in 2021, in 2019. And quickly we have added another 5% by 2021. So we are now 17%. Out of this reproductive age group, probably 1 in 5 to 6 women who is there looking for a child is going to be looking for treatment. Why? Yes, the education, which has given them a lot of extramarital sexual behavior, infections, and related problems. The age at marriage, which is increasing and going high, with the obesity, which is giving a problem, and also the hiking incidence of thyroid. Urban women are more. But however, with all this data which I am pointing out, our incidence of childlessness is much better than what is there in the developed world. With all these things, we are going to increase by 2030. It will not be 17%. It may be more than 35%. That means every third married woman is going to seek support for childlessness. Now, coming to the cost. What do we mean by cost? We all think only drugs. The drugs are the only direct medical costs. Can we cut down on the laboratory? Can we switch off the air conditioner or anything? Can we switch off the incubator when it is not being used? Do we not requiring cleanliness every day as the laboratory junior embryologist to go and clean the laboratory? Just because we don't have a case today, can we go without cleaning it? No, these are all direct medical costs which have to be then and there applied. The non-medical cost. Yes, she is taking a bus and coming to meet somebody at Trichirappalli. She is coming down from Illapur, someplace. She started at 6 o'clock in the morning. At 10 o'clock, will she not be hungry? Should she not eat? Does it not include the cost in the indirect cost? Yes, it has to be. The amount of pain, anxiety, discomfort, loss of enjoyment, because she is coming to a hospital, she is going to this place, she can't go to a movie, she can't go and enjoy with her friends, she cannot even wear a good sari, which she likes to wear every day. All these enjoyments are being lost in her juicy period of 25 to 40 years. Kindly note, I have given the last sentence. Private care includes $18,592 equal to 15 lakhs rupees. It has been quoted by one Professor Sangamitra in 2018 in a journal who is an index journal, Shanlak's International Journal of Economics. This is one end she has quoted. At the same end, her another paper has been quoted by an Indian economist journal, where she has put the reproductive technology for the low and income, this thing along with these people, and she says 30,000 to 50,000. Is it imaginable to do an IVF? 30,000 rupees right from writing the case history down to delivering a baby? Even our own non-medical economists give a baffling idea about what the doctors do, with the result public do not know what to do, where to go, and how to this thing, feel that this much is the expense that an average IVF, to all my knowledge, in many of the centers, with all the unexplained infertility alone, may cost from 1.2 to maximum 2 lakhs. Maybe sometimes even 1 lakh. But however, all the other things, whichever has been said, is not correct. So these sort of the same professor giving two baffling different newses, quoting 15 lakhs and 30,000 rupees, is one thing which is not putting ourselves into proper limelight also. Can we say low-cost IVF to doing it with IMSI, ICSI, donor programs, PGD, all hatching procedures, third party and fourth party, we can do low cost? Kindly say no to it. We can't do it. Then we were doing happily gamete sharing, embryo donation, all these things left and right, front and back, pre-ART bill. Now, after the ART bill, we have to have our hands crossed for this also. In the era of ART bill, we can't do any sharing. We have to go as per laws. At the same time, we have to support the lower socioeconomic status also. That means, what do we mean by average cost for an average patient? What are all the averages which are required? Age, the menstrual cycle characters of the female, her ovulation status, the male, and the general parameters are to be average for this to have a cost-cutting effect. Age has to be less than 30, preferably never above 40, please think of a cost-cutting procedure. In between age depends on the other averages. Male age presently is kept as acceptable as per ART laws. The sperm has not been given any difference as per the age. Health status of the male, yes, average sperm and parameter, average sexual health, and absence of any infections, specifically urinary tract or anywhere. For the female, the health status has to have regular cycles, and she should not have any fibroids, endometriosis infections, and anomalous uterus. These things do not allow us to talk about cost cutting in the era of ART bill or in any other time also. In the general health status, the female has to be preferably non-diabetic, non-hypertensive, non-cardiac, non-epileptic, not physically child. These are things not for the IVF procedure. It is for the pregnancy, because now the ART is take home, live birth, healthy babies. For that antenatal period, all this diabetic, hypertensive, cardiac give a lot of hue and cry and problems that they add to the cost of the IVF procedure also. If the patient is distantly placed from a medical support area, that is also a huge increase in the cost of the patient. Preferably, she has to seek a center which is nearer to her, which also is able to give her a good ART support on. The direct cost, as we are coming down, it includes right from investigation. A consultation doctor, private, cannot be doing free consultation every day because no nurse comes without payment. The doctor also has no house without a rent. So she has to have pre-IVF investigations, which may take about 10 to 15,000 rupees on an average. Medication cost of the drugs is one thing which we are thinking of a cost cutting. And probably the pre-IVF investigations, if there is a public clinic by the side, she can definitely use it so that she can cut the cost. And in the IVF procedures, she can think of alternates of IUI and IVF for the laboratory part of it. Post-conception is the one. Once a urine test is positive, should she travel all the way to the IVF center to have her checkup, or she can have in the public setup, which nowadays also gives her properly careful, detailed antenatal tracking system. Delivery cost also depends on whether she is going to deliver a singleton or a multiple pregnancy. All these things are also going to add to it. Where she can make a compromise is general checkup in a public forum, and post-pregnancy follow-up, post-urine test follow-up in some of the public clinic facilities where she is able to have a one-to-one contact with the primary health center doctor also with this. The indirect cost coming to us, the pre-procedures checkups have to be made very clear so that it is not unnecessarily every day coming. Place of stay, she can find to be accommodative, comfortable for her. Maybe we need not admit her for home retrieval or embryo transfer. Luteal phase can be followed up at home. But the sudden surprise, even if she turns out with a fever by day 28 or 26, which may be a viral infection, but still she has to come to the hospital, which may not be avoidable also. So with all these things, this ideal couple who is available for this cost cutting is the one who is nearer to a hospital, doesn't have any health issues, willing to go to any place which is able to give her a good support economically. And she should not have all this 3rd month, 5th month, 7th month, 9th month rituals, going from Trichy to Karur to Chennai to Ramanathapuram and coming back to Trichy. Because she will be put up to multiple doctors and that will also hike the cost. I have seen patients who have come down from Karaikudi. Just for her bangle ceremony, she went back to Karaikudi and she had bleeding. She had to keep quiet because the bangle ceremony has to be over. Then she rushes back to see that the baby is dead in utero. So all these religious procedures also the patient should be able to forego for that pregnancy. That means a loss of enjoyment, can't help it also. Unexplained infertility is the best one. However, I make it very clear. The cost reduction cannot include a basic serology, a diabetic checkup, a health checkup for the male. Semen storage should always be done as a precautionary procedures, and the couple should find a residence near to the hospital. Probably if the doctors are doing a group sharing practice, they may also be able to cut down the cost for the patient hugely also, because the consultant room and other things comes to be a little less expensive for them. Probably the patient cannot go without an ECG or echo, and probably she may not require IENT or any other checkup. She always requires one cycle at least with a clomiphene challenge test so that we know what drugs to minimize her. Do we need AMH as a test is a question. I'll come to that soon. You will be able to get the answer. So the cost cutting means respectively treat her with probably doing a scan by day 3 and having had a cycle with clomiphene or letrozole plus gonadotropin. Simplify the laboratory needs, which are the ones which I am going to talk about it. As far as possible, avoid complications. Manage the luteal phase with a proper protocol without making the patient come and go frequently. And once she is pregnancy, probably should she go to an early pregnancy unit is a question. This is there outside this country, but in our country, we don't have the EPU. Probably we may ask the patient to go to a good obstetrician. Geeta Nargund, Datta, Stuart Campbell are people who have done decades of work on cost cutting, ISMAR. They sing minimal stimulation protocol is their hue and cry for the past 3 decades. So the day 3, patient comes to the hospital and June 2020, that's 2 months ago, fertility sterility says very clearly, if patient has done all the other tests, please call her only on day 3. So probably you evaluate whatever records she has got and also look at the ovarian reserve, and the male partner also can have on the same day do a semen analysis also. All the other details can be done all at one stop. If everything is all right, probably we may not require HSC, we may do a sonosalpingogram also. Probably if she wants that cycle itself to start her ART, you can start it on the next day. That is what couple of months ago, the fertility sterility volume talks about one-stop center, one-time visit for cost cutting in ART procedures. We all know very well, since 2 decades, 3 cycles of IUI is equal to 1 cycle of IVF with gonadotrophin stimulation. But this gonadotrophin stimulation gave a little high multiple pregnancy rate, and here it takes 3 cycles of IVF, means it takes a longer time, and the patient also feels whether I should go in for a dilemma of IUI to IVF. Are we having any recent work? Please wait for my lecture to be completed. Then we have the culture process, laboratory process. Of course, right from 1956, when this EBSS medium was brought, right now to the G1, G2 medium, all the other changes have been brought out, but we used to make our own media at that time. Now we all are using the media which is being brought from the companies only. But this, it will take a long time to go for any other change also. In 2017, WHO was trying to find out whether it can poke its nose in the infertile couples by giving some guidelines. But it found that the use of minimal IVF alone may not be able to help in all patients. But however, if it is used, it is not giving a lower birth rate. So it said in ACT couple, we can use the minimal stimulation protocols. What does ESHRE and ASRM says? ESHRE makes it very clear with the standard stimulation protocol is equivalent to mild stimulation protocol with antagonist protocol, not with the agonist protocol. If you are going to reduce the gonadotrophin dose, thinking that the patient is normal, your outcome may be little, outraged. You may not get the same outcome. ASRM makes 150 units IU is better than any higher dose. But however, still this ASRM is not being accepted after the optimist study also. Right. Yes, we have done about this. How about if you are able to get more eggs, we can cryopreserve so that we can have better outcome. When you are getting more oocytes, especially in polycystic ovarian syndrome patients, that means a patient is expected to go in for hyperstimulation syndrome. She may bleed. She may have other complications due to the high yield of this thing also, oocytes also. But here, the targeting the oocyte number is not going to help you, as presently the dictum is clinical live birth rate per oocyte that you have retrieved. The current protocols for minimal stimulation is not a fixed minimal dose, maybe a dose altered to the patient's convenience with oral compounds which are being added, as Charmila has talked about, clomiphene citrate or letrozole, whether it's a centrally acting drug like clomiphene citrate or peripherally acting drug aromatic citrate, which you can use it as per your disease. But with these things, the live birth rate is good. The cycle cancellation has also not been found to be bad with these cases. So this thing, apt couple, apt dose of minimal dose is always accepted. When there is a normal responders, As I said, look at the Optimist trial about the gonadotrophin dose 150. It has found that it can be used in the underprivileged where patient does not afford to have cycle monitoring frequently. Probably we can think of using this. And here, this Optimist trial also found out that it does not require the antral follicle count exactly to be made with the high-end ultrasound and also the AMH level. This study is one of the largest study on ovarian stimulation, which is still being taken up in the last 10 years. And it says only the female body weight and her age is the cause of the failures of live birth rate rather than the AMH and AFC. Now, we were talking about 2004 study on 3 IUI is equal to 1 IVF. Do we have anything now in the present? Yes. They're saying New Zealand is doing that study called a fixed study. IUI and IVF in unexplained infertility is being put out. 4 IUI plus 2 low-cost IVF is equal to, 2 regular IVF. This is what is going on in New Zealand. The sample size as which was started in 2019, the sample size is supposed to be 580 on each arm. That means it has to have 580 on the arm of IUI plus IVF, 580 on the other one, and 6 fertility clinics are going on doing this work. And the outcome is not only live birth rate, it is also looking at the time, the viable pregnancies, the biochemical pregnancy, ectopic stillbirth, the number of embryos. So it has got a long way to go in this. And it is also looking at the cost per live birth, cost per couple, the need for hospitalization, drug reactions, and deaths also is being looked at. All these things, this fixed study is going on with the eligibility, which we have talked about for an unexplained one without any female and male factors also. So it is also very categorically, it's not looking at patients with endometriosis, fibroid, and CAVI patients who have got a enlarged uterus with adenomyosis, blocked tubes, and patient who had clipped tube for hydrocephalus. All those patients are excluded in this fixed study. If you have anybody in the Auckland, New Zealand, you can send that patient for this fixed study group so that she can be included in it. She will have a less cost and get a better baby also because the study is still ongoing. Now, what can be done at the laboratory level, which we started in 1980 to 2000, which we are still continuing with the ICSI, IMSI, IVF and other things. Now, this is what is called the intravaginal embryo culture. This is really little more popular in the United States of America. It is called the InvoCell. Approved by the FDA, it can hold up to 7 oocytes for 72 hours of culture in the vagina, and live births and neonatal health are all reassuring, and it can be kept for 5 days in the vagina. This is the InvoCell. The cost is around $1,200, $500 compared to the laboratory cost of more than $4,500 in USA. The InvoCell, ovarian stimulation, follicular puncture, gamete, everything is the same. After the follicular puncture, getting the gamete is put into the InvoCell. The semen sample also collected is put into the InvoCell. The InvoCell is inserted into the vagina. When it is vagina inserted, after 3 days, it is being looked up for the embryos and the embryos are transferred. Can we do embryo cryopreservation, other things with this? Yes, it is also possible. That is what is the real world experience of this InvoCell has been brought out by RBM just about 3 months ago. And it also says the technology is compatible within the current framework of practice of the doctors. Appropriately used, results are acceptable. Blastocyst recovery also is good. Live birth rate is also good. More clinicians should take up the InvoCell. That means more Indians have to take. I talked to a couple of Indian senior doctors. They have used 4 or 5 cases InvoCell. But since our patients' acceptability is very much has to be there in this sort of procedure. Then we don't have patience to counsel the patient, and the patient also doesn't have confidence in doing such a simple procedure to get a baby. That is what is called universal yields steady reports live birth rate comparable to the traditional IVF. Only thing is the progress of embryo in the 3 days which is kept inside the vagina cannot be monitored. The mini IVF, if it gives 35 to 40% clinical pregnancy rate, universal gives 30%. That is all the difference. Only thing is the clinician should come forward using the universal. Now, the second one is the Journal of Clinical Medicine has brought out it is also in the month of June, promising perinatal outcome after using a simplified low-cost IVF culture system specifically designed for low-resource poor countries. What is this? That is from USA. This is from European countries. Omblet, Nargund, Stuart Campbell, and Von Blercom are the people who are involved in this. And in 2014, after about 3 years of work, Von Blercom reported 11 healthy babies born out of this fresh embryo transfer and also frozen embryo transfer using this simplified culture system. This is called TWE-Lab Simplified IVF Procedure, and the reference is Facts Views was Obgyn 2014. You can take a photo shot so that you can go into it and look at the details of this. And the entire procedure simplified culture system is given very clearly in this one. This is a simplified culture system. You don't require a big incubator. You see the 2 tubes, and it's a temperature control and carbon dioxide control and other things. To expand it more, this is composed of only 2 vacutainer tubes. One tube has got the solution which can generate carbon dioxide through sodium bicarbonate citric acid releasing sufficiency. The other tube contains a culture medium with the embryo with the gamete, and the pH has to be maintained between 7.29 to 7.35. How do we find it? You will see the picture and you will show that. Only thing that has to be very clearly kept, the outside variability is temperature, which is kept at 37 degrees for the culture. You see, this is a system. The A is the one which has got the 2 tubes with the connection. B is the one which is showing the tubes which are being connected. You can see the system is good. The solution, the embryo culture system is pink. That means it's good. And with the same thing, you can take the tubes and look at the, they say scleroscope and look at the embryos. See the pink color with these tubes. This is a simple system. Only thing is the temperature has to be maintained adequately by the system properly. To put a little better picture, you see the tubes which are to acutinous. You see it is being looked at under the microscope. If the pH is 7.3, it's a color. If the pH is 8, it is going to be the color. That means you have not maintained the laboratory properly. And they have shown a picture of the embryos nicely also. So with this picture, you can find out you require 2 vacutainer tubes and a connecting tube and a solution for getting the carbon dioxide properly, and have the culture medium in another tube maintained with a pH of 7.29 to 35 with a stereoscope microscope which can look at the embryos. You don't require big microscope, and everything is there consistent with temperature maintenance, pH maintenance, and other maintenances which is there in the traditional IVF system. After 2014, in 2022, Reproductive Medicine Bioline came out with a paper. They have sibling oocytes. That means in one cycle, we take 8 oocytes, put 4 in the simplified culture system, 4 in the traditional one. That is called sibling oocyte demonstration of efficacy. That means the oocytes are of the same characters. So one focus is kept up, and this has shown that it is equivalent to the conventional XA system. Will it affect the embryo quality and the endometrial receptivity? Will the implantation be a failure? No. It has shown very clearly, whatever we have the oocyte cavity, the laboratory has got the dependency on the embryo transfer, depending on the air quality, embryologist, training level, and the incubator. Whereas here in the simplified culture system, these three things are taken out. It is the quality and quantity of this culture material which is used without any gas phase, oil overlay, or tissue culture waves. With the result, this endometrial receptivity question is not questioned by the laboratory procedure. So, a simplified IVF system compared to the conventional one. In the conventional one, you have got check at every level with the air, incubation atmosphere, culture media pH, and temperature regulation. Whereas here, everything is simplified and it is able to make better. In TWE project, if you go into it, you will see all these pictures very clear. The TWE project finally says, the V lab with simplified culture system looks at all the male factors, female factors, and they have started slowly including them also into this simplified culture system with minimal acceptability also. And this came out saying that they have looked in 2022, 7,915 oocytes with a clinical pregnancy rate of nearly fertilization rate of 61, implantation rate of 50, clinical pregnancy rate of 32%. Their traditional IVF is 37, and their simplified culture system is 32. That means there is no statistical difference for this. So this is why they are able to do this ACS left and right, front and back is because the Belgian government has given the support. The reimbursement is done by the MBS. It is mainly to see the cost cutting at the medical gases, incubation equipment, consumables, and the infrastructures. And it can be used even with 1,000 to 5,000 motile washed spermatozoa. We don't require the 50,000 motile washed for the IVF. The couple characteristics have also been slightly fine-tuned to female factor can be there even up to 34%. Even there can be a male factor also, which is acceptable the same. Combined female and male, in the last 10 years work, they were finding it in 15%, giving rise to the same 32%. And they all have used only antagonist protocol. This is the Walking Egg Foundation, which is taken up by William Omblet, Geeta Nargunda, and others. And they have founded clinical birth rate cycle of healthy babies are also good, and the surplus embryos can be cryopreserved in the normal way in which we cryopreserve the traditional IVF and ICSI embryos also. So the promising work by Journal of 2023 a couple of months ago on low-cost IVF specifically designed for resource-poor countries. We all know about Muhammad Fatullah, who is a great social obstetrician, whose dream has come true, is coming true if only you youngsters, ART people cooperate. He argued that sexual reproductive health for all is an achievable goal. He said, if only you are able to make it cost-effective interventions and properly scaled up, political commitment is revitalized, financial resources are mobilized, rationality is allocated, more effectively used by the clinicians also. They saying we can reach everything to these people also. How about our own father, Bob Edwards? He said we should go for accessible and affordable IVF. Accessible to the patient and affordable to the patient, affordable to the doctor also. He was person when he is talking about, he was a great scientist. Apart from that, he was also a person with a lot of general knowledge. When he talked about it, he was mocked at as he is over enthusiastic, too ambitious to be in every field. When he went into the media to publicize his first report, everybody mocked at him. But nowadays, what we do not come to the conferences to give our reports. We go to the Economic Times, Hindu, and others only to give our report. And all these things has made the evolution of his generation. William Omblet had his PhD in male factor in 1998. I have been there with him for 2 sittings of 4 weeks for andrology training. So he has been a counterpart with Bob Edwards, and he has now come out with a fee, making us nearer and dearer to accessible and affordable IVF. So what was like this to this patient, a big dream. Can I go to the IVF center? Can I get a baby? No, she can actually be in the falls itself. So the curtain is raised now. It is for the youngsters to utilize these opportunities. All the IRT people, please put your children, the next generation, to these sort of centers for training and make them fine-tuned to accessible IVF in our country. Thank you very much for the patient here. Charmila?
Unmute ka? Akka, unmute.
Manju?
Madam?
I have finished.
Thank you, madam. Thank you so much for such
He
a
gave me 40
wonderful
minutes. I
talk.
finished at 40 minutes. What, Shanti?
Looking like a dream, madam. What you taught us right now. So
Yes,
just-
I get yourself unmute.
You have to read this further, madam.
Which one? What I said last.
Yes, madam.
Yes. You want
Yeah,
me to put it
read.
back? No.
Yes, ma'am.
I'll send you the slides. Charmila, I'll send the slides to Charmila.
Okay, madam. Thank you, madam.
Yes.
I've taken pictures of all your slides, madam. All the ART talks, I've taken pictures, madam.
Okay, thank you very much. Everybody is not unmuted except myself and Manjula. All are muted.
Kindly unmute Charmila, ma'am, please.
Charmila, you see, they have to, the host, Shield Pharma has to unmute. Sahitya? Sahiti has to unmute.
எல்லாரையும் மியூட் பண்ணிட்டாங்க.
நீ மட்டும் ஜாலியா பேசிட்டு இருக்கலாம். But they will be hearing what we are talking.
Yes, madam.
Yes, because when the Kanjivaram Society for their annual meeting gave me the low-cost IVF, I was thinking, what am I going to talk for low-cost IVF when we don't do the gamete sharing, embryo sharing or anything? What we can do? Because converting an IUI to IVF also is not that easy, because you have got level 1 only accreditation for your center. You can't do IVF in your center, isn't it? Because you have been accredited only for IUI. So the government laws are going to see. Then I looked at it. Then I went into Geeta Nargund and William Oblet. I know these two people are always towards minimizing.
Yeah, just now she's unmute. Yeah.
Minimizing the cost. That is where I got this paper. And
At last I've been unmuted.
Shanti, everyone, ask him to unmute everybody.
Sahiti, please unmute Dr. Sri
Everybody,
Shanti,
everybody.
Dr. Nalina
Okay.
Devi, and everybody, please. Please
Everybody.
unmute all the delegates, please.
Yes, anybody can have questions.
Ma'am, I such a wonderful presentation, so comprehensive. That experience which you have was totally shown in each slide. It is so, it is like going through an encyclopedia of how to run an IVF center, and each slide had so much of meaning. And I was seeing the InvoCell which you were talking on. It is said $1,500 you said, but when it translates to Indian money, it is 1,25,000. But we do much cheaper than that. We don't.
That is why I did not talk too much about InvoCell.
InvoCell, yes.
InvoCell.
Because we are
Yeah,
cheaper
yeah.
than that.
Yes. For them, an IVF cost is $20,000.
Yes. It's much
20,000
cheaper.
is the dollars, in which laboratory is 4,500. For them, cutting down to 1,200 is acceptable, but not for Indians. That's why still couple of people in India also tried in metro cities, but the patient's compatibility is very much less. So they have not taken it very much in InvoCell, because we have to depend on, and our climate is like that. Patient is very much scared that it may fall down at any time.
Yes.
But
And,
still,
yes,
even this 3 months ago, they have FDA has reapproved InvoCell.
And the simplified culture system which you were talking about, suppose a youngster wants to start a center without any this thing at this time, I think they should go for a simplified culture system because
Yes,
that seems
yes,
to be less expensive than the labs which we are running for almost 10
yes,
years now.
yes.
So that's a
Yeah.
good take-home message for the youngsters.
If
Suppose
Aditi wants to go for this infertility, you have to send her to this thing, TWI
Belgium.
center. There are 27 centers in Europe. Then
Okay.
right now, Geeta Nargundi is at Belgium. Belgium, Paul Devray was the one person who was doing a lot of work 3 decades ago in IVF. And now Paul Devray has kept down. So there are 27 centers in Europe. Probably we can contact Geeta Nargut and probably send mail to her in this, and she may be able to put us in one of the centers. She is an Indian. Geeta Nargut is an Indian. She is quite a short person, 4 feet 10 inches. She is shorter than me. Because I walked along with her and I was thinking, I'm a little taller than her.
But I heard her talk in Eshrei. She is so passionate about low-cost IVF and just, I think, spoken in some Delhi meetings also. We have heard her
No,
talk.
she is very pathetic. She makes big. She begs people to use it. She has done 3 days, 2 days, 4 days conferences on ISMAR, minimally stimulating IVF. I have attended those things also.
So the summary of the talk will be to cut the cost for the patient, go for a minimal stimulation, as you said. Do not go for
the cost. You have to use the public system for basic investigations. You need not do hemoglobin, blood group, RH, this thing, HbA1c, thyroid test in your private laboratory. Allow her to do it in the, let her go for a female master checkup in the public sector. She can also have a basic scan in the public sector. Male also can have a semen analysis in the public sector. In the drugs, when it comes, you give the drugs which are, they say, CC, letrozole plus gonadotropin. That is where you cut the drugs. In the laboratory system, in the probably admissions or hospitalization, unnecessarily we do not admit her and ask her to come every the second day, 9th day, 11th day, 14th day, like that. So probably have this thing with the other doctor in the local area whose picture she can send by WhatsApp so that he can see the follicles and decide on, because our own this thing is what is required. Then come to the laboratory. Luteal phase, probably put her on more of this thing, oral drugs, which are also nowadays acceptable. She can do a home monitoring urine pregnancy test at her home itself. And once she is UPT positive, probably you can request her to meet your this thing, supporting obstetrician in that area. And she can continue that up to then. So that the antenatal care is taken care by them. It is not only the laboratory, every phase she has to have the approach towards it.
So the message to Manju is, if you want to start a center, you need to go to Belgium and try to procure that simplified culture
Not
system.
Manju. Manju's daughter is doing medicine, no?
But she has to start.
No. I don't want Manju to go and learn and come and do it for 2 years and keep sleep. I want Manju's daughter to go to Europe and learn this system, come back and start the system and train everybody else also. See, Priya finished her, they say, embryology master's graduation when she was 27 years. Now, she is around 45. For the past 19 years, she is able to teach others also. Like that, you should do it in your blooming age, learn it, and do it for a longer time, teach others also.
Manju thinks herself as a bloomer, actually.
Okay,
because she
you.
wanted the topic to, I think, to cut the cost of setting a center in her place. Is that right, Manju?
Yes,
Or you
all
wanted to
other
cut
things
the-
Manju can do. She can do the public health setup, low cost drugs and other things. For the laboratory, I would like an youngster to go and learn it so that energizing the youngster learns. Okay.
Thank you, madam.
And if your lecture goes viral and everybody starts listening, people who are running apartment complexes for IVF centers should have shut down, I think.
Yes. And they say, this night on, RIA will kill me. I don't care.
You said
They
all the
cannot.
All the antenatal care will be taken care of by the government centers, and
Yes,
you do the IVF procedure and send the patient, and
yes,
it's like many will have to shut down then. So that was
yes.
nice.
We have to know that this thing earning by ourselves to the end is not going to support us.
Yes.
Isn't it? Money is
ma'am.
not everything in life. We should know. That is what Muhammad Fathallah made it. He made a hue and cry. It is where patients are dying not because they have the disease, because we are not looking at it properly. I have seen Muhammad Fathallah in 1997. He is such a great person. And Bob Edward also told us once, if I find somebody who is, at that time it was only 15 to 20%, this clinical pregnancy. He said, if somebody is able to make this 15% to 50%, I'll prostrate before them. Bob Edwards said. Now we have come to 50%. He is no more. But the next one he said is, make it affordable and accessible. I think that we are now going to take it.
Thank you, ma'am. Shanti, would you like to ask something? Dr. Gayatri? Shanti, would
Nandina
you like
is
to
also there. I saw Victoria there. And Priyadarshini.
Sahiti, you can unmute all actually.
Yes,
Gayatri,
ma'am,
ma'am,
I
would you
have
like to say
unmuted.
something?
No,
Gayatri, ma'am.
it's too overwhelming, ma'am. While we play the second innings, I thought of reducing the workload to hand over to the next generation. But now I'm once again inspired. Why not try in the second innings itself?
We'll go to Belgium together, madam. Gayatri, ma'am.
We all will go
So
to
let me just, that's why I put it that way. It's too good that to, retain whatever ma'am has said. I need to listen to it once again and imbibe completely to, put it in action. Sure, ma'am.
It's when
Thank
the
you so
result
much.
is
It is so
8,000
inspiring.
embryos, we have to take it up, isn't it?
Yes.
And Belgium is not a country where you can do ART outside. Every case has to be registered with the government. Belgium and all are
Their
very
rules
neat.
are so stringent.
Yeah.
But as you said, an IUI cannot be converted that easily to an IVF is also due to our registration problems.
Yeah, that is what I said. I did not talk about IUI to IVF mainly because all centers were registered for IUI.
For the level 1 like
Yeah.
us, and then
Yeah, you cannot do.
we
That's why I
can't do
didn't
that
talk about it.
also. Yes, ma'am. That bottleneck is there, but that's
Yes,
why
that is why in the era of ART laws, we can't convert. Suddenly you tell the patient, you go to the next center, and the patient gets emotionally drained.
yes, surely. Yes, ma'am. But we'll listen to this once again to imbibe it completely. And where do we stand and then act accordingly, ma'am.
Oh, yeah.
Ma'am, it will be available in the Shield website. You can go and see in the Shield Connect website.
Yes, ma'am. Sure. Thank you very much, ma'am. Thanks a lot.
Thank you, Gayatri.
Shanti, would you like to say
Very
something?
nice.
Shanti is nodding, all already drained.
which is the best IVF center in Belgium, ka? I'm seeing in
No,
Google.
you put the TWE Foundation, you will get the address. That's what I said. There are 27 centers throughout this. I think there are 3 or 4 centers in Belgium, 2 centers in France, 5 centers in UK. Like that, Germany has got 3 centers, totally 27 centers. That is in 2022. Now, how many we have to see?
Thank you so much, ma'am.
Thank you.
Nalina, would you like to say something? Nalina, she's joined.
She was there.
Nalina, would you like to say something? Low cost IVF in Perambalur. You're not audible. Victoria has joined. Victoria, would you like to say something?
Nice talk, madam. Very nice. And I felt that cost cutting, as far as we are doing, is we are doing the IVF part in our center. And the patients who are not able to afford the antenatal care, they go to the GH, and then they come and show the baby and all that. So that's the kind of cost cutting we are doing right now. It's happening right and left. Many of them are taking that step of going. They stay with us till the NT scan. and then they proceed. So that's the only way we are trying to do cost cutting now, and it's working out very well also.
Very good, very good, very good.
Because already labs, I don't think we are as expensive as the Western countries. So that
Yeah.
cost cutting, we can't go beyond that. So
Yeah, that we
that's
can't do.
what-
We are giving only the basics, basic amount only we are collecting.
If
So-
you are able to make our IVF something affordable to totally from entering the hospital for getting a baby down to going out with holding the baby in her hand, probably
Yes.
with 1 lakh, everybody should be able to accept it.
Yes.
And that's what I too
We
think.
don't charge anything extra. We don't tell anything differently from the beginning and suddenly add some cost. That are all we're trying to do.
Yeah, yeah.
As far
yeah.
as possible, we give them a full picture in the beginning
Mm.
itself, and then they have no problem usually. Very rarely for this freezing and thawing and all extra sometimes it
Isar
comes, but
gives
otherwise
this sort
we
of
give them a good picture from the beginning, what
Yes.
will be the expected cost.
Isar gives some this thing, scholarship like that, where if you write all the details about the patient and send the income certification properly, they give about 1 lakh to the patient. In that 1 lakh, many patients are able to save 4,000 to 5,000 rupees for going home with the baby for this. They would like to travel back home in a taxi, you know. Till the time they will be using the public transport. I tell them, don't use a taxi and tell me that you have drained the amount.
Mhm. But truly now it has really come down. The cost has come down and more people are finding it affordable, and we have more and
As
more
we have
cycles
got more
because
and
of that.
more people going in for infertility.
Yeah, and more
20,
indications are also
70%.
there.
Now
More
it
and
is
more
going to be
indications are also
25%.
there, and more are able to do. That's why it's increasing. The number of cycles are definitely increasing, and it's become easily available to all also because of the extremely sudden increase in the number of centers. It's easily affordable and accessible to all. In Trichy itself, there are so many centers.
Yes,
So,
that is what is required.
Yeah.
Thank you, ma. Thank you.
Mm.
Thank you
Any
so much,
questions in the
ma'am.
chat box?
No questions.
No questions.
Everybody is happy.
Yeah.
Everybody will go and see the lecture again to actually imbibe what has been said, because it was like every slide had so much of meaning inside. So I think we need to go back and read through to understand more. And probably in the next thing, we'll add our questions to the next lecture. which will
Oh,
be the
yes.
next
When
one.
in the next lecture, probably first 10 minutes you can leave for this. And that is what we discussed, you know. The
Yes,
first
sir.
10 minutes, we will have the questions of the previous lecture. Probably if the lecturer is joining, they can answer. Otherwise, we ourselves can answer. That is what we were thinking, you know. Yes.
Yes, ma'am.
Yeah.
Okay.
Yeah, thank you so much,
Thank
ma'am.
you.
Manjula,
Thank you.
thank you,
Thank
ma'am.
you, madam.
Manju, vote
you.
of thanks, please. Manju. Okay, I'll say the vote of thanks. Thank you so much, Jem ma'am, for joining us and giving us such great insights. It's actually, as I said, it's like going through an encyclopedia in a short period of time. Thank you so much for that insight which you gave. I'd like to thank Dr. Shanti, the president, who has joined, Dr. Manjula, the treasurer, Dr. Nalina, the EC member. I think I saw Shanti Priya also. Thank you so much for joining. I'd like to thank all the delegates who joined in great numbers. Please go through the website to check for the recording and go through, and please come back with questions that will always add value to the educational program. And we do. Thank you so much. I'd like to thank Shield Pharma for all the support, especially Sahiti. Thank you so much for all that. Thank you, ma'am. Thank you.
We all greet Charmila, who is going to the second FIGO conference. Both the conference she is a faculty and she is going to chair a session on 12th. So she is going not as a delegate, she is going as a faculty, chairing a very, very important session on 12th. Greetings to you, Charmila. Probably when you go there, if you have any of these people, Tree Foundation should be having this thing also.
I'll talk to them. I'll come
in
back.
the exhibition room.
Yeah,
Find out and talk to them. Okay.